Hello, everyone, and welcome to our second episode of our podcast. Today, with myself and Professor Johansson, we're going to have to give a brief overview about frailty and what frailty actually is, and how that links to a patient's outcome, and really the link between frailty and acute care for a patient with hip fracture. And as we briefly mentioned on our podcast, we're not just a duo, it's actually a trio. We have our third member as the, say so, typical patient who might come in with a hip fracture. So that's Grace. She's our typical hip fracture patient in her 80s. She's living alone, but with help from a family. She's got a number of medical comorbidities, as well as memory difficulties. And just coming to you, Professor Johansson, what can we tell her about the outlook for a patient with a broken hip? I know, of course, during my training, I remember the mortality for a neck and femur or a hip fracture was very high.
Yeah, so that's what people think, and that's what people have been told. And she's if she's in her 80s, she will know a number of people who've broken their hip over the years. She may well know somebody who's died following a hip fracture, and about a third of people used to, and about a quarter of people still will die in the year following a hip fracture. But that's because this is a condition that affects very old and frail people, who are coming to the end of their life anyhow. Actually, deaths directly related to a hip fracture are perhaps half that figure. And death in the month following a hip fracture, so really directly associated with the injury, is down at only a few percent. Uh, but
So,
that's not her. Yeah, that's not her. That's not her perception, and that won't necessarily be the perception of her family. And there's a real there's a real concern that people come in, they're frightened, they are despondent about making a good recovery, and their family lose the belief that somebody could potentially get back home to living independently if they've come in with a hip fracture. So we need to debunk some of that, and be more positive about it nowadays. Hip fracture care is a real triumph.
okay, so what we're saying is the actual risk of a patient with hip fracture isn't as large as we typically think it might be.
No, and when people write grant applications asking for money to do research on hip fracture, they always talk about how a quarter of people die following it. But actually, dying as a result of your hip fracture is much more uncommon than that. We did some work a few years ago where we looked at patients presenting with hip fracture, and with many thousands of patients coming in with hip fracture. We looked at the most sick, the most complex 10% or something like 10% of them, people who the anaesthetist, when they saw them before surgery, viewed them as an anesthetic grade of 4 with incapacitating systemic disease. So it's about 1 in 10 of the patients we see that's true of. And we look to see exactly what happened to that group of patients, to see what the outcome is, even for a really sick group of patients. And they did have a poor outcome, um, but actually that wasn't a poor outcome around the time of surgery. 99% of those patients, the most difficult, came through the operation. 99% of them came through the next day. We only lost 2 or 3% of people in the perioperative period. Even in that really sick, complex group of patients, the vast majority of people will get through. And as a result, we shouldn't be frightened about orthopedics and anesthetic care. If you don't have surgery and you're left in bed with a terribly painful hip, unable to get up, unable to move around without pain, developing pressure sores, people give up and die. And that was the situation 30 years ago in the UK, and remains the situation in some parts of the world, that it's really challenging to survive a hip fracture. But actually, hip fracture surgery doesn't really carry a risk. Um, and if we want to rename this podcast series, we need to be thinking about it. It's not about the orthopedic surgery. So we should think about the podcast series as being the rest isn't orthopedics. It's everything else that's wrong with patients. And during people's time in hospital, we lose perhaps 0.5% of these very sick patients during each of the days following surgery. But for the majority of patients, 90% of patients are fitter than that, and they're going to have better outcomes.
I like the title. I hope we're not ripping off too many other podcasts. But I think, as you mentioned, it's really interesting that the worst or the most ill of these patients still surviving the surgery 99% of the time, and the issues come later on down the line. So, as you mentioned, someone who's medically unwell might do badly later on down the line. Is that to do with frailty? And can you really explain to me? I know it's a very complex topic, but what frailty actually is and what we really mean by it?
Yeah, so the word frailty, I think we need to be really careful about how we use it. It's very easy for us to look at somebody from the other end of the ward, or when you're walking around town, and to think this person looks frail, and you're making all sorts of judgments about them. Patients don't like being thought of in those terms any more than they liked previously being labeled as too old for surgery. And that was a situation. So frailty can be used pejoratively and is resented by patients. Frailty really has a very specific meaning. Um, and what it is a complex weakness, a vulnerability of some people, which it comes through their accumulating impairments, physiological and functional impairments, things that accumulate over time. So as time passes, I will lose nephrons, I'll lose neurons, I'll lose neuroconnectedness, my heart and liver function will gradually deteriorate. But none of those necessarily will deteriorate to a degree that cause me a particular problem. But the accumulation of lots of different things not quite working so well leaves me more vulnerable if I put an extra strain on the system. And that's what frailty is, this vulnerability due to an accumulation of deficits. And that's not something that's really measured. We typically people have a clinical frailty scale performed when they come into hospital, but the clinical frailty scale is not trying to identify frailty. It's not measuring people's frailty as I've just described it. What it's trying to do is predict people who might have frailty, and it does that by looking at how dependent they are. So people who are needing lots of help, functionally very impaired before coming into hospital, needing a lot of help before coming to hospital, are likely to be frail. But being frail isn't just a measure of how dependent you are. Being frail is this accumulation of multiple physiological insults. And we did some work on patients coming through our unit some years ago. And what we found was that if you ask 50 questions about each person who presents with a broken hip, you'll find that each of them has about, on average, 15 other things going wrong at the same time. And those multiple problems are what leaves them vulnerable when they come into hospital. So those problems may be coexisting medical conditions, maybe coexisting psychological or psychiatric conditions, memory problems, or it can just be functional problems, the need for help and support in activities of daily living. And it's that accumulation of things that is the challenge for me and for the MDT with which I'm working in trying to support somebody who's come over with a hip fracture. The hip fracture is the easy bit. The frailty is much more complicated, much more challenging.
So the frailty is almost like a state of vulnerability, you might say. And obviously, as I think you mentioned, the average patient has, on average, 15 medical, psychological activities of daily living issues. So I think, as you mentioned, I think we haven't really talked about the comprehensive geriatric assessment yet, but really using that to really get to the root of these problems, I'm guessing is why it's so important.
Yeah,
Um,
yes. Yeah, so I can't do comprehensive geriatric assessment. I can contribute to it, but I can't do it without the rest of the team. Uh, I need the nurses, I need the therapists to be pulling together information, to be making assessments, talking to patients, talking to their families, and pulling together a really complete picture of what's wrong with the patient. Not just looking at the X-ray and saying we need to put this piece of metal in here, but looking at the whole patient and the whole psychosocial context of that person. And that's what comprehensive geriatric assessment does. And we know that comprehensive geriatric assessment is effective wherever it's done, in whatever condition it's done in. And in hip fracture care, that's what I try to pull the team together to deliver for patients when they come in.
And for a patient when they are acutely admitted, for a hip fracture patient when they are acutely admitted and they are also frail, what's some of the most important things we have to manage and really look out for?
Yeah, so it's very easy to be distracted when you sit in a meeting in the morning and somebody's come in overnight and there's an X-ray up showing their fracture, and then there's a long list of medical problems that could cause a problem. That could be a challenge to them and make you feel despondent about how well they're going to recover. It's very easy to be distracted by patients' frailties, all their physiological impairments. But we shouldn't be distracted by those. Many of those problems are going to be there when they go home again. They're not, these are permanent difficulties, many of them. They're not going to be cured by an operation. What you shouldn't be is distracted by them. And I think it's really important that the MDT, a properly constructed MDT, will tackle and deal with and support patients through the challenges imposed by their frailties and their vulnerabilities. And we'll talk about those in further podcasts. But actually, for the admitting orthopedic team, the anaesthetist who's seeing the patient and planning to take them to theatre, there's a really important challenge that they need to face in terms of what they need to deliver. So I've said orthopedic surgery is really good, anesthesia is really good, but the joined up nature of care in the perioperative period is really, really important.
And what is it that these surgeons and anesthetists really need to focus on early on that ensures good care for these patients with hip fractures, for example?
So their objective might be to try and get her straight to theatre as quickly as possible. Her objective, Grace's objective, is to get better and to go home again. That's what she wants. And so what she needs to be is not, she's not in a rush to have her operation. She's in a rush to have a successful operation that means that she can get out of bed and start eating and not be confused by her hospital environment. That's what she wants. If you talk to people who've recovered from hip fracture or struggle to recover from hip fracture, it's very clear that that's what they're after, is to be starting to get back on with life again. And what the surgeon and anaesthetist need to do is to make sure that not only they give a painless, comfortable operation, the patient's not bothered, that's successful anesthesia, that they've got the right piece of metal in the right place to allow the patient to be up and fully weight bearing the next day. But they also need to deal with the main physiological stresses on this frail patient. And you, you can think for a hip patient with a hip fracture of really just three physiological stresses that are involved. The first is that a patient who comes in with a broken hip is bleeding. They're bleeding internally. We don't see it. They're bleeding into the tissues in the leg. And unlike somebody who comes into hospital with a gastrointestinal bleed, where it can be all over the place and it's very dramatic, these patients can be losing quite a lot of blood, and they will lose. So some fractures will lose a pint, but somebody who's had a more complicated fracture and somebody who perhaps is on anticoagulation, which 10% of patients are, will lose potentially 4 or 5 units of blood between the time they break their hip and they've finished surgery. So huge blood loss, and we need to be thinking about potentially transfusing people so they aren't too anemic the day after surgery to be able to get up. We need to be thinking about trying to minimize bleeding. So making sure that we think about tranexamic acid to minimize bleeding in theatre. We need to think about how you address the patient who's on anticoagulation, turning off warfarin with vitamin K, getting people's to theatre in spite of the fact that they're on DOACs at an early opportunity once you're confident that oral anticoagulation is not there. But tackling some of those challenges. So we need to think about managing hemorrhage aggressively so that being anemic, being hypovolemic doesn't put an unnecessary strain on patients and lead to other things decompensating. Their brain and their kidneys are totally dependent on perfusion. And if they drop their brain perfusion, they become delirious. So they drop their kidney perfusion, they'll develop an acute kidney injury, and those are a problem. The second physiological implication of having a broken hip is that the patient becomes immobile. So they're at risk of pressure sores. We need to do something to prevent that. They're at risk of um, they're at risk of deep vein thrombosis, pulmonary embolism. So we need to make sure that they're on appropriate chemical thromboprophylaxis to avoid that. Uh, they're not going to be able to get to the toilet. They're going to be incontinent. If you can't move in bed without excruciating pain, you're going to be incontinent. You're not going to be able to get to the toilet. So you need to think about how nursing care is organized to ensure that people can use a bedpan with dignity. Don't just stick a catheter into everybody and say we've cured that, because catheters carry their own problems. But thinking intelligently about management of the patient in bed to maintain their dignity and their comfort. And then the third physiological stress that people are under is that they're in pain. And we need to do something about that. Um, you, everybody can have paracetamol. It takes the edge off things. Um, but if I went to have my teeth drilled by my dentist, I wouldn't want to have paracetamol before he started. I I wouldn't actually want to have morphine before he started. I'd want him to give me a nerve block to numb the area so that it doesn't hurt. And nerve blocks are something that are really powerful as a way of reassuring patients when they're in casualty, to try and prevent them being frightened and in distress when they're being moved from one bed to another to X-ray and so on and so forth. It's also something the anaesthetist will do post-op to try and avoid people being distressed by pain in the night after theatre, so that they have a good night and are ready to get up and getting moving the next day. But the main purpose of, or a major purpose of having a nerve block is to reduce how much morphine you might need. But people will need morphine levels of analgesia if they're going to be able to get up. Even after your operation, your hip is going to be sore. It's going to feel as though it's had a good kicking. It's going to be very bruised, and people need to expect that. They don't want to come back from their operation and find they're still in awful pain and worry that something's gone wrong. They need to anticipate it's going to hurt and be reassured that that's fine. And then that needs to be managed carefully with appropriate use of opiates and opioids to make sure that they're able to get moving, but not so over-treated with painkillers that they become muddled or constipated. And it's that attention to the physiological stresses that patients are under that surgeons and anaesthetists need to deliver. If they can manage the hemorrhage, the immobility, and the pain, HIP, if they can manage those three additional stresses, then the frail patient won't decompensate. And when people do decompensate, the commonest thing that we see, you may be able to measure a mild acute kidney injury, but the thing that we commonly see is people becoming profoundly delirious, confused, and distressed. And that's definitely a topic that we need to tackle in our next podcast. So we need to find ways to structure the care of people when they come into hospital, so that the MDT can look after the frailty, but the team looking after the patient in the perioperative period minimize the stress on that frailty, so that people are ready to get going again straight afterwards.
Oh, well, that's a pretty neat acronym, HIP, so hemorrhage, immobility, and pain. Yeah, well, thank you very much for the brief overview of acute care for these hip fracture patients, and it's been really interesting, Prof. Johansson. And again, thank you very much to the audience once more for listening. And make sure I'll again include all the links, references in the bio, and hopefully tune in for the next topic on delirium, I believe. And look forward to see you then. Bye. Thank
Bye.
you.